actual support. We're trying to do the best we can, but we feel very confident this is close. So you're looking again, this is not different than other states, but it's important for you all to know. And why is it important? Because we've said from the very beginning, this is the area of the population and the services you as a task force should be really focused heavily on. Because you haven't been in the past in the sense of the state. The state has focused a lot of its efforts on the medical home model and the primary care for the lower cost segments of the population. So nearly half of Medicaid is long-term support services and other medical, and this is just a breakdown, again, to show you in a graph, diagram. And if anyone has any questions, just don't hesitate.
So right now it's working.
Elder care, we've been around, we've talked about a lot of these issues, so they're not going to be not familiar to you. Elder care in HALO is about $1.2 billion, 29% of the Medicaid, 65% of your elders are in nursing home. Depending on the program, HALO could add 10 to 60%, and we're going to show you where those HALO costs are. And even when you consider all that, your nursing home cost is still about 3 times your waiver cost per person. And when I say that, you also, the assisted living is a little higher, so you have to look at the different costs, and we're going to show you the average breakdown. And this is directly from the state's decomp total spending of $989 million here, all on elderly care. And you can get to see the breakdown, and you'll have plenty of time to review this on your own. And I know you're going to hear from folks, and you may want to just look back at some of this when people are talking about the programs. But I think it's important here, and you start looking at the difference between, I want to point out a couple things. 53 is personal care. You see 98 million. Those folks are in the community. So when you say, okay, waiver, we're only at 53 million and nursing home is 600, that's not, you shouldn't look at it like, well, nurse, institution versus waiver. Institution versus community. A lot of the folks underneath are getting community support. Like the personal care is community support. Assisted living is community support. Some of the AR seniors is community support. And we're going to give you the breakdown of what the actual costs are. But this goes to another issue on the waivers that we're going to talk about when we get to our final report. Personal care is a state plan amendment service. Your elder choices is a waiver. Some of the services are similar, but you're managing 2 different aspects. You're managing a state plan and you're managing a waiver. And this is just one of those 6 or 7 waivers that we showed you. And it becomes really difficult to manage all this. And we're going to be talking to you about a more global approach.
John?
Yes.
I've got a question. Senator Sanders, you're recognized for a question.
Thank you, Mr. Chairman. Just real quick, because I want to make sure I understand what we're talking about. When you're talking about total spend, you mean total spend fed and state dollars,
Yes.
correct? Do we get to some point later on, we'll give a breakout of what the spend is on each of those categories by fed and state? Because I think for our budgeting purposes, that's probably what's going to be most critical.
We don't in this presentation. We did earlier presentations, and we are in our final report going to have some modeling, which is going to be state impact versus federal impact. So that will be in our final report.
Okay. And again, I think that's what's going to be critical for us when we're making our decisions is if, you take one of these categories, if it's and I'm just making it number, if it's a 10%, 90%, state versus fed, and that's, even though the dollars may be more, the true dollars to the state may in fact, that may not be where we should be focusing.
Most all of these programs, these are programs, this is not private option. Most all of this is 30 or 30% match.
Most is 30% match with
yes.
some bed tax that gets multiplied
yes.
and some other
yes.
things. Yeah,
I
just want to make sure we take all that into account. All right, thank you.
And I appreciate that question.
You're on, John.
The halo effect now accounts for significant costs for each type of elder long-term support services. So when you start breaking it down, what's interesting here is the elder choice waiver, which you would expect, seniors on the home waiver, are going to be using more of your medical costs that are not related to the supports waiver. But the institution is also using medical costs not supported under that institutional payment. And you can see assisted living is the same, so you can really get a sense of what those true costs really are. Because when you start looking, Senator, at how much you can actually pay aggregate total, you need to know what is not just the institutional waiver costs, what are all the costs together. And we're going to be, when we model our savings projection for you in the final report, we're going to be going off of the total cost projection picture. And then when you look at these are number of elders in care in a given month that are billing Medicaid. It may not be the exact number that are capacity, but it's the number that are billing at a certain point in the month. We took the full year, we looked at how many were billing after day 15 in that month. We took them all together, we aggregated over a 12-month period. So these are the actual calendar 2014 individuals that are billing. Elder choice waiver, you had 4661. The slot might be a little higher, and it might be a higher capacity now, but that was 2014, the number that we're billing on average. And the member months are important because that's what you base your total budget on, the number of member months, full year. And this may be important later when you start modeling and looking at community first choice and savings projections and go back and look at some of these numbers. Nursing home costs are twice as much as home and community-based services. Home and community-based services here are merged of all the home and community-based. And those are the personal care, including the waiver. I wanted to give you the full picture. And in the full picture of home and community-based, you're talking about around $27,000 a year versus the $63,000 in public-private nursing home facilities. And it's a little different. The cost of public is higher, as you can see over here on the left, versus the private nursing home. But there's so much fewer on the public versus the private. But aggregate, $63.6 thousand per year per individual is a number that you can feel very confident. Now we're going to move to developmental disability. And we've gone through a lot on the nursing home and the elder side already in the home and community-based waivers. Now we're talking about a different population, developmentally disabled. And today you're going to hear from folks that are going to talk to you about the wait list, I think, and some other areas of developmental disability. So it's really important that you listen to them as well, take into consideration some of these factors. Your beneficiaries account for about $900 million. 23% traditional Medicaid. Your institutional HALO costs 2 to 3 times the cost of program. But most of that institution are folks in your state institutions that you have. I think there's 6 of them, and you've got, or 5, but you have pediatric, you have some other development disability institutional. So if you look at it, it is going to be much cheaper in the community. We'll show you some of those numbers. But it's always difficult to transition. There's other issues, and we're going to put some stuff in our final report that talk about how some states have done this, if you want to go in that direction and look at some transitions. But it's not about the cost all the time, especially with this population. It's about the quality. It's about making sure the families that are involved are also involved in whatever process happens. Stakeholder input, everything. So when we look at disability, including Medicaid, the same thing as we did in the last. Most of this is your regular max, not private option, but
John,
these are your categories.
John,
Yes.
excuse me. Senator Rayford, you're recognized for a question.
Thank you, Mr. Chairman. John, on that, I wanted you to drill down, if you don't mind, just a little bit on, when you talk about the institutional care, you did mention the human development centers, which you mentioned, and other. What all is included in this number? If you would be just a little bit more specific, because this has been an issue we've been dealing with for a few years.
If you go to slide 12, I think it's 12 right now, I'm pulling up, you'll see a line there, 27. That's your pediatric institution cost.
Okay, line 12
There are
down.
5 of them, and there are 50 or so on average, I think, in each. About 50 in each. So what we've done, Senator, is we've basically looked at DD and didn't aggregate it out based on age. I mean, it's developmental disability costs that you're paying in your Medicaid program. And so those are really your institutional, and then you have, and here's where it gets
it gets more difficult, because you have your ICFs at a certain amount, and then you have a group home, and CMS may characterize 16 or more as an institution. And you may have people in the community providing quality care in a group home setting that's at that level or even smaller, that they don't consider institution costs.
Right.
So you may be hearing a lot of that as well. But those ICF costs, I believe, those ICF costs are included in the 62.
I just have one final question at this point. And I forget now all of the different states that you've consulted in and where
Yes.
you guys have provided input. In the state of Vermont,
Yep.
one of the state senators there serves on the National Conference of Insurance Legislators with me, and has talked at length about the fact that many years ago, Vermont basically closed down every single institution that they have.
Yes.
And we know that there are people in our institutions here that I'm told by many community providers that they simply can't handle. And the state senator in Vermont advised me that they are now looking at going back to having some in those settings because they found it even more expensive, because you have basically one person that is getting 24/7 care on their own somewhere in a community, rather than having maybe 6 patients that are monitored by a nurse during an evening somewhere. I just wondered if is that a true statement? Is she advising me clearly on that situation?
I will start, and I want to hand it off to Richard, because Richard was actually in Vermont.
Okay.
And he was there during that very time. I will tell you though, Senator, because Vermont and New Hampshire border each other. In our state, we took Vermont's lead, and New Hampshire did the same thing and eliminated institutions and transitioned those families to community. And we passed statutory law back in the 80s that says no one can be placed in any facility more than 2. So by statute, the legislature took a handle on it. It significantly reduced costs overall. And the experience increased quality, but the experience is, what you're talking about is, there are individual cases. And you start looking at certain cases that if it may cost a lot more in the community, it may go beyond your average cap and your waiver, but you look at it in the aggregate, it's much less costly. But there are issues involving transitions that you have to take into consideration if you move in that direction. Richard?
Thank you. Yeah, I was actually back then when the plan was made to close, and I was there when Brandon closed. It's a difficult question today, because the economics of Medicaid have changed a lot. But I think that clearly, states that have closed their institutions, ICFs, state institutions for ICFs, and there are 14 of them. Some of them are pretty big, Michigan being one of them. For them, they've been able to do one thing that may be a challenge, but also an opportunity in Arkansas. They've been able to develop the level of the community's capacity to deal with higher needs people. And along with that comes a financial strategy. In some ways that states haven't closed all of their institutions in order to serve people with high medical complications, in some cases ventilator-dependent people. Here you have Mount over in Benton, which I visited 2 weeks ago. And other people with aberrant behaviors that are simply not acceptable, perhaps forensics-related people, have kept some of those folks in state ICFs or community-based ICFs. The question becomes whether or not you can increase your overall waiver costs for that proportionality of higher acuity people while you work with the provider community in the community to develop their capacities to handle higher levels of acuity in terms of what your average state ICF cost is. In some states, waivers have put a cap on community waivers at the cost of their state ICF. So what I'm saying here is that for Arkansas, the question is you've got about 950 or so people in state human development centers. If you chose to take a look at that, the opportunity would be to increase the acuity level capacity in the community at expected higher expense per waiver individual, and where that sits into your overall financial plan for developmental disabilities, and whether or not you do it in a managed care framework, which is another question, or whether or not you continue to do it in a fee-for-service basis.
Well, that's all for now. Thank you for that. But I know that definitely we have to think about any kind of ramifications if we head down that road. Thank you, sir.
Thank you. Seat 22, Senator Elliott, you're recognized for a question.
Thank you, Mr. Chair. This is kind of a follow-on to Senator, I'm right here in front of you,
Wait,
right here.
oh, sorry.
Kind of a follow-on to Senator Rapert's questions. I know I have constituents in the audience who would be dying for me to ask this question. In the transitions from institutions to community care, are there any states who have done this, not completely, but as a hybrid, with the recognition of maybe there are needs that maybe demand, or it makes more sense to have a hybrid of it? And if there, just a quick description and tell me which states, so I could look at it for
I'm gonna let
myself.
Richard, he was the director in the state of Washington when they were doing this type of
Okay.
transition.
I didn't, wasn't a director DD, but I,
But would you explain what you mean by hybrid, which, so that I will know what we're talking about? I know what I have in mind, but it'd be nice for me to know from you too.
well, what I understand is a hybrid state system is a system that has a community first choice option,
Mm-hmm.
but has the capacity built into it for the state to take on the responsibility for those individuals who cannot thrive in the community or
We're
be
exactly
safe
on the
in
same
the
page.
community.
Okay.
And as I said earlier, the cost factors involved with that, however the state determines to construct their budget around this population.
And which states are we talking about? Senator?
Washington, that's one I can tell you right offhand,
Okay.
because I was there. There's several others. Texas, to some degree, is in this. Texas has 3,300 people in state ICFs, and they've had a slow direction towards community-based care for people that in the past would have gone into state
Mhm.
ICFs with higher level of acuities, as they've been able to develop person by person the capacity in the community to treat them.
All right, thanks. That's it, Mr. Chair, thank you.
Thank you. John, you continue.
Okay, so the same thing for the development disability costs, looking at institution versus Halo costs and community versus Halo. We call it direct program costs. In the institutions here, again, 27 is your pediatric, your 62 is your public, and some other ICFs that I believe are private that are I guess, designated ICF. And the question is, you don't think of them as, they're not like the Human Development Centers, but they're larger capacity individuals in one facility, one area, one congregate home setting. And you basically can see the costs. The next page is really the direct program costs, and you can see the difference. So now we look at the direct program costs in the community. And you can then take each of the areas, we looked at the claims for each of the areas, and you have, OLED is an interesting one because that's your day programs, day rehabilitation. Why that's important is because we're going to show you that there's some individuals, many, on the wait list that are getting day programs. So you may want to know, well, what is the extent of those day programs? What type of activities do they get? So when they say someone's on a wait, it's not exactly they're waiting for a waiver service, some are waiting for something. But there are a number of services here that we were able to get all the costs, and we broke it up into, we went to the school-based RSPMI, we looked at some of the community children medical services, and we looked at your public and private, as well as your OA day hab and your alternative waiver. The waiver is D1. So when you hear someone say, I'm waiting for a slot on the waiver, that's the alternative community services waiver. The waiver itself, we're going to show you the cost difference, and we're going to be able to show you how many are on claiming on the waiver during that given year, and that's coming. So, but this gives you an idea, when you have time to look at it, really of what the percentage costs are attributed to each of those, program versus Halo. So you can see, significant amount of medical costs for those that are also claiming day hab, and there's significant medical costs for the alternative waiver, as well as some on the institution. And this is more of the head count. So these are people that are billing Medicaid. Don't misunderstand this with the number of people that are actually in a bed at a given time. It's not about capacity. This is about over an average period of 12 months, how many are billing per month, because there might be some Medicare billing too. So we want to make sure we were as exact as we could be for you, because if there's Medicare billing, that's not affecting your budget, but most of those will be dual eligible, and it's not much here, it's some in your elder areas, in your nursing homes. So this is, if you think about it, you're probably going to have over 4,000 on the waiver, but there's average of 3,886 that were billing during that 12-month period of 2014. And the ICF pediatric 27, you can see the number there, 202 versus the 1,238 in the Union Development Center. This takes all of the community spend, compares it to institution, and when Richard was giving in the first month the Truven data and showing where you stand with regard to other states, that you're at 50% spend in the community, 50% in institutions on DD, and many states that have really done it in a very well methodical, well thought out, and more community-based way are more on the 80-20, even better than that. In our state, it's like 99. Vermont is 100. But, you know, every state's different. But you're really looking at 50-50 on the adult side. You add the pediatrics, and then you add all the other community services. We wanted to be accurate here. You're at about 25% of all your costs. That's the state of Arkansas. Yes, Senator.
So, run this by me again. So when someone says, I'm on the CFCO waiver, it's been capped at 3,000, that doesn't mean they're not getting services.
We're going to get to that. So if you can
Answer later then, please do. Thank you.
And that's the alternative services waiver, not the CFCO. CFCO is not a waiver. So then we look at the cost. Now, just like we did with the elder institution, we're going to compare the institution costs per person on average with HALO against the community. And these are the numbers that we received from that 2014 and actually compared to the claims. So it's not just the 2014 spending, it's the claims that we received. So we started comparing and we looked, and this is as accurate as we can get. And you're looking at about $68,937 for, that's that, Senator, that's the waiver when they talk about wait list. And that's the D1. And then the day treatment, you can see there's the cost of day treatment only on average per year, and you've got the cost, the rehab services, and we're going to talk about some of the RSPMI later. And then you've got your institution costs. And these are your ICF merged costs. And then you compare adult, just taking that so you have the comparison between the adult and the pediatric. And then you can see the difference in the pediatric. So now, Senator, we're going to get to the wait list. So we had asked, and it's a concern of ours all along, and we've been in a number of states where if individuals say to representatives and legislators that there's a wait list, and it is 2,900, whatever it is, sometimes the perception is that these people are out there waiting and getting no services at all. So we wanted to make sure that we could at least show you a picture of, are they getting something? And what is that? And we asked the department, and it took them a while, but they finally were able to get that information to us to their credit, and they really had it well defined and dissected down to all the claims, and we were able to analyze it. And this is what we've come up with from the department's data that they gave us. And when you start looking at it, you can see that just these are some of the claims. There's other claims, too, that we didn't include, but you can start to see some of the claims. And again, I point you to 08 is your day habilitation. That's a very important one for day treatment, clinical service for some of the folks on the wait list. But the perception is they're not getting no service. But then again, there are, I talked to Director Bader this morning, I believe the number is somewhere around 2,900. I had it written down that are actually on the wait list. It's 2,900. So out of our 2,640 that are claiming, there are some that are not receiving anything, and that is correct. But this gives you more of a complete picture. Here are the most frequent claims. You can see non-emergency transportation is used by 2,500 individuals that are on the DD wait list. Again, what are they waiting for? They're waiting for a slot on the waiver. And I will go over why that's important in a minute. You can see some of the services here. They're still getting their own Medicaid, they're still getting the physician services, and they're receiving some additional services that are non-medical. This is, you know, you may not be able to read this on a copy, I don't know, it's small print, but I wanted to give you an example of two. So this is the data set that we received from the department. So just to give you an idea, I've taken out any information there's no identifying factors at all here. But you can get a sense, these are two different individuals that are on the wait list. And this is during the year. One claimed $33,000 of services, and one was at $44,000. One had 12,000 on day rehabilitation, 12.7. And you start to look at, so what we did is we went through every cell of every individual and then aggregated it for you. But I wanted to give you a picture, just so you can see, again, there are services that these folks are getting. But it's very spread out, and it's not meeting some of the needs, too. And I want to be clear on that. So what are the key factors? You're going to be thinking about wait list. And you already did, and you're concerned about it, and you'll probably hear about it today. And every state has that issue. It is an issue in every state. The good news is your elder choice waiver
Director Seelig, and I'm trying to really move those numbers to a lot closer, somewhere around a 50-day, 45 to 50-day period. But there's still a significant amount in the backlog. And that's a concern in nursing homes, and it should be. But key facts to consider here on the wait list. Ensure that the funding requested takes into consideration the community services that are being rendered. Ensure the payment is for supported living is appropriate. Now, why do I say that? Because really what is happening in the wait list, the waiver is you're going to be able to get supported living, which you don't have in the non-waiver services. So supported living is an important component, and it's one that is important, but yet you've got to make sure it's appropriate. And there are issues that states have looked at in making sure that relative care and any other setting has good assessments, make sure that the level of need is correct, and you're not paying more than you should. This becomes important. Ensure, again, standardized assessment. Richard has talked about that from day one, and independence.
Hey, John, can I just ask real quickly? You've given us two examples of the 2,400 people on the wait list. And in these two examples, you know, the average beneficiary receipts are something between $35,000 and $40,000. So are these two outliers at the top of the 2,400 and everyone else is at zero, or are these representative? Or give us a little context. Is everybody on the wait list, we're still spending 35 or 40 grand a year on them, or are these two outliers?
I wouldn't say they're outliers, because the 2,600 that are receiving service are receiving a good amount of array of services. The costs are higher on the high end. Some are down to $700. Others go up, and the mid-range is about $20,000 possibly. I don't know the exact, but I have to look at it. But I mean, you're talking a spreadsheet of 2,600. I'm just trying to condense and give you a couple of examples. I think those examples were somewhere towards the low 10% range. Question whether, and this is an issue you need to look at, 20% administrative cost for providers. Now, on the waiver, there's a 20% administrative cost according to Directed Cloud, and this is something that, in my opinion, and I know providers may not like this, but that's your decision. You need to look at that. Because what is the incentive for a provider to come in, and I know they're all good-hearted people, but what's the incentive for them to want to keep the cost low when they're getting 20% admin on whatever the cost of the plan is? So that's an issue that we're going to obviously want to address, and you're going to need to look at it. And those are the types of issues that should be addressed, whether you, Richard said, whether you go managed care, which are already being addressed in managed care, they address that, or whether you go into either primary care, medical home, or any other model that you pick. It's an issue that, and what it comes down to is what I come down to is this. I've said from the beginning, do you have enough money in the system today to really meet the needs of the people out there? I believe, and we believe you do. But you just got to find those efficiencies in those areas.
John, I have another question. Senator Sanders, you're recognized for a question.
Thank you, Mr. Chairman. John, on the most recent guidelines that CMS has put out for managed care on administrative costs of balancing the MLR, they're looking at 85/15 is the breakdown. Is that looking at an aggregate cost, or have they trying to think back reading through those long pages of material? Is about what is an acceptable rate on the admin side when we look at other states, some other states that are doing with fee for service? What do you typically see?
I don't, the admin rate of 20 is high. Is actually high. In the DD area, it's high. Relevant disability area. But my point is that might be efficient if they're doing really good work and can minimize the costs and make sure the individual gets the right service, right time, right place.
Yeah, and so in that 20% admin, that would be, if we were to look at the cost for an assessment, would we attribute an assessment cost to the 20% cost, like moving forward?
No, that's all
Okay, fair enough.
in addition.
So that is 20% cost now. Now, in a managed care environment, in that construct, within that 15% guidance that they're giving now for the MLR and the admin cost, that would take into account a managed care provider that is using an internal assessment.
Yes.
So truly, if we were to try to mirror, because everyone out here keeps telling me, oh, we can do this on our own, and we can handle this, we can do this on our own. But the truth is, we're not doing the things today that are necessary to ensure that we have the people getting the right care, the right service at the right time.
There's no question that you're not doing all of the things you can. But I will tell you, and again, you can do better. The people that are providing the services are doing good quality work. We're not finding anything that's minimizing quality. But I will tell you, state of Texas, they have managed care in that state. Don't think the 15% is what you just have to stick to, because that's what CMS says.
You can write contracting.
Whatever contract you want. The state of Texas, 7% experience rate, and you come back value-based, and the managed care companies have to pay the state back anything above that 7%. And it's monitored because they have people there that really know how to make sure that.
Again, so we're talking about currently now, 20% admin cost, no risk accepted by any of the providers today. The risk is all back on the state.
You know, you hit a point. We're moving towards our final report. At the end of the day, you have a lot of contracts out there. You've got great people providing great service in all these areas. There's no risk.
Yeah. So
The entire United States and Medicaid is all moving towards risk. So you hit a good point.
Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. I may restate this question in a different way, but just for clarity for my purpose, if there was a third party that did an assessment that didn't have a dog in the fight, there was not the fox watching the hen house, how much of that 20% could be trimmed down, or have you run any numbers or done any estimates to determine that if it was a third party doing the assessment to determine needs, how much cost savings would we experience, how much of that 20% would be reduced?
It's difficult to answer that question. These are two different entities. There's an assessment being done by an entity, Pine Bluff assessment. And then there's providers that are going into the home determining on the assessment the level and working on the plan of care. And so what you have is, and that component is getting to 20%. Pine Bluff is also being paid for their assessment. But I just want to make sure we're on the same page.
But that's in just one area. But if that concept was expanded across the board into all areas, what kind of savings could we realize if that philosophy is applied in all areas? Whether you call it managed care, whether you call it somebody who just has an independent set of eyes on a scenario in all areas of Medicaid.
I think from our review, and we'll have this in our final report, we're going to be showing you states that have gone to 2 different directions, managed care or primary care or medical home like you have today, and savings estimates that we've received from the states. So you can just assume that within those savings estimates, they do the assessments, the companies. Those administrative savings are all going to be absorbed in those outsourced methodologies, whichever way you go. But I will say, and this is what's really important, I want to be clear, our thinking is, when I say there's enough money in the system, the point is there may be individuals out there that need help, that need something. And the question is, at one point, and you're paying 20% for providers to go in, when there's some folks over here that may need some help on other services. And when you start really looking at the whole picture, you have enough money to spread around to take care of the needs of the population that needs to be served at that level. That's our feeling.
Thank you, Mr. Chair.
The 426 or 4265 waiver cap can be eliminated through, when I said the global Section 1115 waiver. This is an area where we're going to start talking a little more in our final report. We'll probably talk about waivers, but you have caps, and each waiver has certain restrictions and limitations. So in your development disability waiver service, you have a cap. So the director has to manage it to that cap. So in essence, you have a wait list. And so the question is, under a different 1115 structure, could you serve more people? And other states have actually done this and have used savings in that structure to take care of the population that needs additional services, versus just keeping to a straight cap, where you can maybe set the cap. And maybe you should have flexibility so that it isn't just what the federal government and your department worked out in this one waiver. And if it's managed appropriately, i.e. the 20% and all the other things that need to be done, you probably have enough to take care of a lot more people. And you can integrate supported living, and I want to mention, I stress, supported employment. Because many of the development disability populations, especially in other states that we've seen, they really need help with supportive employment. And again, to a value-based type purchasing situation, you could change that 20% and say, guess what? We're going to pay you the 20% if you find a good job and if you do X, Y, and Z and meet these benchmarks. That's the approach that you might want to look at. That's not the approach today. Supportive employment is important for those with developmental disabilities. So we're going to get the behavioral health, and I know I'm mindful, I want to be mindful of the time. This is your RSPMI costs, your community counseling, and also your clinical and your inpatient. And it's very similar to what we run through with the DE. We'll now show you some of the claims. There's really looking at RSPMI costs, a pretty significant cost in the community. And we believe unmanaged. There is a vendor that's looking at the front door, but when their only prior authorization is 5% rate, there's a lot going through that's actually getting out to the community without any real good, meaningful oversight. You're going to hear from the providers today too. This is our breakdown, the same behavioral health costs, inpatient, outpatient, community, RSPMI, and it comes to about $464 million in program costs. Program, not Halo program. Richard, you may want to talk about this slide. I know this was important too on average inpatient psych and some of the observations you had. You want to run through these next slides?
Richard, can I just get you to hold for 1 second? Senator Rayford, you're recognized for a question.
Thank you, Mr. Chairman.
Yes, Senator.
This is the best place I know to ask the question, and we may get into it later. One of the things that I keep hearing about behavioral health here in our state is a situation where we have somebody that is actually ends up incarcerated. And really the situation is a mental health issue, and I keep hearing we don't have places for them. I hear from law enforcement that they're begging for some place that they can place that individual because they really don't need to be placed in jail with other people that are there for real crimes. Is any of that coming to the top in some of your research?
Thank you for that question. Yes, in fact, we will be making recommendations addressing the issue of people with serious mental illness and criminality, particularly low-level crime. Higher-level crime tends to get into the forensics area. Basically, in a nutshell, the system that you have today, with due respect to all the great people that work in it, is a somewhat fractured system from what other states have been able to do with public mental health. There is no perfect public mental health system in the United States. States continue to grapple, even the ones that are known as the best practice states. The fact of the matter is, though, right now, the way the benefit is constructed, there's no incentive, there's no structural relationship in the actual clinical services that would speak to diversion from a local jail for low-level variant crimes. There's no system in place for public safety, which is critical for people in the community, family members of people with serious mental illness who may be violent. There's no system in place for communities to work together. There may be some that I'm not aware of, but there are no systems that are fostered by the state policy in public behavioral health, although I do know that DVHS has this on their screen, and I think they've made some efforts in the past. But I do think there's plenty of resources, getting back to what John's been talking about in other systems. You've got resources here that if the system, if you had a preferred provider, I know this might be volatile, you opened up your benefit to other providers several years ago because of a lack of access. I think there are ways to handle access issues through preferred provider systems for seriously and persistently mentally ill people and seriously emotionally disturbed children. You want to move to the systems of care. You want to have partnerships with public safety, child welfare in the community. We're going to point out a system in San Antonio, Texas, amongst others. In Washington, we have a crisis diversion benefit that's part of what is here the RSPMI service. So yes, we will address it.
Well, I would appreciate you following up with me because I've had several family members reach out to me, and they're literally begging for help. And law enforcement, is trying their best to help them in those situations, but there's really nothing that they can turn to. So I appreciate your comments on that and answering the question. But I think that it's a very critical issue for many reasons, not just the fiscal reasons, but it is a very critical issue. And so I'm glad to hear that you're looking at that, sir.
Go ahead.
Were you going to respond to that, John, or something?
Well, I think Richard
Okay.
did a great job.
Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. Looking down through here, substance abuse, looks like one of the smaller percentages of that, and I would maybe expected that to be higher. Do you have confidence that that's properly allocated percentage?
This, I believe, does not include the substance abuse block grant spending, which is not under the Medicaid system, but Director Seelig can probably answer that question. So that amount is clearly not enough to address the substance abuse issues in the state, clearly. But there is funding being used in other departments and other grant and agencies, and SAMHSA funded that's clearly looking at that.
Okay, thank you. Thank you, Mr. Chair.
You're good to go, John.
Again, these are all Medicaid claims. So while more is claimed in RSPMI, the average inpatient psychiatric is much higher, and obviously that's an area where many different states have had different approaches towards diversion and more community-based resources, targeted case management, and things that have worked. And we're looking at those best practices so we can have in our final report some ideas for you to reduce the admissions to inpatient psychiatric care. Because we know that that's a very high cost, and it's one that, again, whether it, and I keep going down these two different roads, whether you're in a managed care environment or whether you're in an environment which is primary care, medical home model, you need to move to risk. You need to make sure the providers are trying with the same incentives you all want, working towards a common goal. And in both those situations, when they reduce the unnecessary level and do more in the community, they ought to be rewarded. And it shouldn't be, you shouldn't feel bad about them getting a profit if they're enhancing the quality of care. And this is an area that they will do a better job. I will guarantee you that in the current system you have today. Whoever's doing it, whether it's on the value-based with more medical home model or whether it's on the managed care model. Richard wanted to talk about this slide in particular.
Thank you, John. This slide gives you a distribution of the number of RSPMI beneficiaries and their spend broken down by increments of 1,000. And I think if you're looking at it for the first time to see this kind of data presented like this, what this is saying is that 41% of the RSPMI beneficiaries are using it for less than $1,000 a year in cost, which to me says you've got huge churn, people turning over in this benefit. You would speak to, I would bet, a lot of single outpatient visits or maybe several outpatient visits and no continuous treatment. If the benefit is designed for people with serious and persistent mentally ill or adults, let's just focus on schizophrenia, we would expect that there would be more stability in the number of people that would be receiving services in over a period of time. $1,000 to me indicates a short period of time. It could be distributed over a year, which would mean to me the acuity is low. So the point of the matter is that the lack of a standardized clinical assessment on acuity and behaviors and the risk in relationship to harm to others or harm to self is not embedded in this benefits construction.
Okay. And then you can see the top quartile of the RSPMI beneficiaries claiming 75% of the cost, and 50%, 6% of the inpatient site. And so, again, underscoring what Richard said, low-level RSPMI beneficiaries are using a lot, but they use little inpatient site. High-level RSPMI is using a lot of inpatient site. And again, that can be, we feel, much more properly managed and reduce costs and also ensuring higher quality. This is another one, Richard, that you want, I know you wanted to talk about.
Well, as John pointed out earlier, you have a cohort of people, and this may be the serious and persistent, a high level of acuity, people with serious and persistent mental illness, that are claiming a lot of money, if you will, claiming a lot of benefits. They may need those benefits. But the point of this one is that given the clustering of these folks, what kind of programming are they getting and what kind of continuity of care are they getting in a non-preferred provider system? And I think that's something that would require more drill down, and they'd be very there may be very high quality plans of care that are what would be considered high level of continuity of care. They may have an impact on hospitalization. The aggregate data doesn't seem to indicate that. And the system isn't designed to ensure that the folks with the high acuity and high spend has the types of services that would essentially support them on a 24/7 basis if they needed it, even though the benefit may say that. You don't have a preferred provider system in place to handle that 24/7. And this benefit does not have a targeted case management construction for extremely high acuity people. I know case management is always a slippery slope. What I'm talking about is a benefit like Montana, for instance, of all states, our neighbor state, I live in Washington. Their benefit to targeted case management for people with serious and mental illness is extremely strict. It is focused about people who are at risk of going into the hospital in real time and people that get out. Once they're no longer at risk of going into the hospital or getting or being discharged from the hospital in terms of follow along, they're no longer eligible for the targeted case management benefit. And then the continuity care system goes into their provider system on a community-based treatment. That's the type of targeted case management I'm talking about. But this data just continues to support questions about the lack of a system of care that is focused on continuity across the lifespan, continuity in terms of the ups and downs of acuity, particularly in schizophrenia and bipolar disorder.
Okay, so this is our final section on community first choice option. I'm going to be brief because most of this is just setting the stage again. So obviously there was a lot of discussion on community first choice option. Richard's done some research. We had Richard and myself as well contact some of these other states so that we could see what some of the states that have actually started to roll out community first choice option, what they're thinking. And we've got a few sections for you. We're going to be brief, and then that'll set the stage for later when you hear from the department. And this isn't about addressing the department's plans, because we want to hear what the plans are, but this is about letting you all know from us what this whole community first choice option is about and which states have actually started down this road.
Okay, well, as you know, this is a seemingly new benefit. It actually started being constructed in 2009. It's been available to the states since 2012 when the rule came into play. Possibly 11 you could have gotten in because it's based on ACA construction. Given that, right now, to the best of our knowledge, there are only 6 states, I would add Washington to the 5 that we covered, they just went live, that have taken advantage of this CFCO construction. What it does is basically allow you to take your home and community-based waivers and shift them into a state plan amendment. So you're taking a waiver which you can cap costs, you can cap numbers of people who serve. You certainly don't want to cap the waiting list, but again, as we discussed earlier, that's a challenge nationally. Oddly enough, in waivers, you're allowed to designate certain parts of the state if you wish to. Arkansas doesn't use that. But in a CFCO, it's statewide. You can't waive statewide in CFCO. You do get an enhanced 6% FMAP under K, but I want to be clear, this FMAP is only for your CFCO construction. So theoretically, if the idea is you can take all of your home and community-based waivers, and let's say they're $500 million, and then you put them into CFCO, then you're going to get 6% more money for the $500 million. That's part of the theory, and I've been involved in some of these discussions in my own state years ago. The bottom line here is that you got to remember that this is a choice by the person who's on a waiver. So what you got to do if you're going to make this big shift is you got to get rid of all of your waivers. And this choice doesn't allow for supportive living, and it doesn't allow for supportive employment as we understand it. It also is real clear in the CMS comments on the rule from CMS, this is not a pass on Olmstead. It may help you address Olmstead, but it doesn't hardwire a state against any Olmstead litigation, even if you do CFCO. I just want to be clear about that. That's important. And there's no prohibition from a person being on this and also receiving home and community-based C-waiver services if the state continues to keep any of them. Money follows the person at the same time. You can combine Your 3 waiver populations, if you wish, basically people with long-term care needs, developmental, disabled, people seriously persistent with mental illness, if you wish to. If you have a home and community-based waiver for that population, maybe you don't. In another important provision, you've got a maintenance of effort in the first year, which means if you spend $500 million in the first year, your plan expects to save 6% of that in the first year, or maybe 3% because you got a 6-month startup, you can't do it. You gotta spend $500 million in the first year. CMS estimated, this is in the rural 25 states we choose it, and as we said earlier, it's not like only 6 states that are up and going. There are a couple of states that are looking at this, as you would expect, but so far, 3 years down the road, you got 6 out of 51. The SPAs do not expire, it's a state plan amendment. If you want to change it, you've got to go through the SPA process. To the best of our ability, if you decided to get out of it at some point, if you kept one for 3, 4, 5 years and you got some benefit on the 6%, you don't have to pay that money back. But then if you get out of it, you go back to your regular FMAP, you go back to Home and Community Health Services waiver to replace CFCO for whatever reason that circumstance came up. CMS as a whole is obligated to give a report to Congress in 12/31/15. It's going to be interesting to see how there are some congressional people who have asked questions about this in relationship to why there's so few states using it. States can, have a lot of opportunity to design this benefit within the constraints of services that are available. And then we went into the couple of states here that you can take a look at. And I call these states, there really isn't any useful data at this point. A lot of these are new, relatively new in terms of fiscal year construction. There's always a lag in the fiscal year before you get the fiscal year proceeding year. The only thing I would add, I spent a lot of time on the phone just on Monday with the state of Texas on this because we spent some time there, and they've got a whole series of waivers. And to be honest with you, the Texas construction was anticipating only about a 17% use on this particular benefit. And because of their unique construction of federal waivers, and one waiver that I believe is 100% state funded for a very small segment of the developmental disabled population, was the reason why they went into it. Their legislature made sure that this was going to be budget neutral or cost saver to them, as you might expect.
That concludes basically Representative Collins and Senator Bledsoe, our presentation. We can be happy to answer any questions. Stephen is here and can address later if there's any questions at all on financial budgets that he had put together, projections, episodes, or anything else that you guys had thought about from the last meeting that we didn't cover.
Senator Rayford, you're recognized for a question.
Thank you, Mr. Chairman. Richard, on that commentary specifically, I don't want to slip past this. You said that only 6 states have actually pursued this. And it also, I heard specifically that we lose some control. Is that right? In order to manage some of the caps. And it becomes an entitlement.
It becomes an entitlement, yes. And, this is what I would suggest, if I may. I would look at it, but I wouldn't look at it on a straight line savings construction. I mean, I wouldn't just look at it, we get 6%, and this is what our growth rate is going to be if we don't do anything differently, like you might in 11-15 ways. I think you got to really have refined constructions about what the actual utilization of the CFCO model is going to be, what you're going to actually need to maintain to assure safety in the community, and appropriate supports that are not available in that in terms of the C waiver. Because I don't believe the way this is constructed, that the people with high acuity needs in any of the 3 populations, the CFCO model is going to meet all the needs.
Let's follow up on that. Since you pointed this out, since there are only 6 states that are using that, would you be able to provide us information on the experience in those particular states that have used it?
We'll try again. As I said earlier, we haven't been able to find any data that's available because it's fairly new. I know in my own state, they just went live a few weeks ago, and I obviously know a lot of people in state government, and their construction was narrow, just as I suggested we understand Texas's construction was. So what the message I think that we're trying to relay is this is worth research. It's worth taking and I'm using this word simply as a monetary issue. A conservative construction on this is really recommended in terms of how a state could possibly make this benefit them and not be overwhelmed by the risk 4, 5, 6, 7 years down the road of having a state plan amendment on an expensive service.
Representative Gray, you recognized for a question.
Thank you, Mr. Chair. Just trying to wrap my head around this. So if we went with the CFCO, like we've got the ACS, Elder Choices, personal care, developmental disability, those all have their own either waiver or plan amendment. So what you're saying is we would end up taking all of those programs, essentially stripping their waiver, their plan amendment, putting them all into one state plan amendment, and then would that not allow like each one of these categories of people to all be entitled to the same range of benefits?
Well,
Again, I'm just trying to wrap my head around why we have these broken out by different populations for a reason. If we put them in, is there, I guess what I'm asking is, in the CFCO, is there any way to say that this certain population receives these services and this receives these? In my mind, it would all be under the umbrella of CFCO and everyone would receive the same benefits.
That's a great question. There's a couple of questions in there, so I'll do the best I can to address them. I think the possibility of what you suggest in terms of all these populations being in one C waiver, I think is legally there. I think it's important to listen to Director Selig and his staff when they make the presentations of what their vision is for this. I do think that whatever population you put into a CFCO for whatever purpose that you put in there, that once it becomes a state plan amendment, it is mandatory. I mean, the language is real clear. They must be served. And that's the nature of the state plan amendment. That's balanced off, and that's why I think it's important to listen to Director Selig. What do they project as the impact? What are the savings? What are the risks? What are the pros? What are the cons? And I also think this is another one of those areas, like 1115s, like the private option. You want to have a discussion with CMS before this, and you want to make sure your discussion is exactly what you want. In this particular case, anyway, because this is a state plan amendment, see what they'll do.
Okay, could I have one follow-up, please, Mr. Kidd?
Yes, ma'am.
All right, thank you. And I guess maybe in my mind, I envision maybe like an 1115 waiver where you say, you negotiate with the feds, with CMS to do like a 5% growth rate, and then possibly, if you only end up at 3%, you can take that savings and put it back into the program to help serve those people that we currently are on the waiting list. I mean, that's something that we could do ourselves without CFCO.
I think Representative Gray is right on the money in terms of what, we've talked a lot about this idea, and it's what the state of Rhode Island did. So it's not unique, right? You'd be the first. But to take the savings off of the trend and be able to use them to help the population, however way you decide, is something that you want to be able to negotiate. Because you can sit there today and they may say to you, like they did in Rhode Island, well, if you spend $1, you're going to match it. And Rhode Island was not allowed to use all the savings. And another state down the road may be able to. And it all goes down to really what they decide in the long run, because they have the clear authority to allow you to use those savings in whatever way with their approval. They sometimes hold the cards, but it comes down to negotiations, as Richard said.
The other thing I followed, last week John and I were meeting with professional folks over at TennCare to design the rather exceptional progress they've made on moving the long-term care system into home and community-based services based on former Governor Bredson's groundbreaking legislation 2008. They passed that without a negative vote in the House and the Senate. The bottom line is that TennCare, like they do in just about everything today, they look at every opportunity to get the state in a better position with CMS, and they determined that they were better off doing exactly what you could do with the CFCO through an 1115.
Thank you.
And if I can add, because it's important, because we don't have an opportunity, you'll see in the final report some thoughts. A lot of it, the levels of care, the assessments, the issues that are really the nuts and bolts of how this all works can all be, should be, determined by the state. And as long as the state is coming in our view, and this is what Rhode Island did, and they said, if we can show you that we are moving to a community-based structure and reducing our high-level focus on institutional care, and we show that through the savings, will you be able to agree that we could use some of those savings for these things that would not be otherwise available under Medicaid? For example, in Rhode Island, a prevention level of care for seniors that were at risk for institutionalization, not at the nursing home level, and were not eligible for those services beforehand. All now we're able to, under the 1115, be provided with prescription drug coverage, under the donut hole, being able to provide some personal care to try to shorten that time period when they really need that more high-level help. So your point, Representative Gray, is so important to what I believe, or we all believe, that you have to be looking at finally as a recommendation.
John, this is a great example of, this concept of what do we need when we say a recommendation, because your final report's going to have lots of recommendations, and I think we've talked, there may be a bucket of recommendations about the expanded Medicaid population, the folks that are on the PO today, a set of recommendations about saving money from the total Medicaid budget. Maybe there's another bucket of recommendations, which are high risk, high reward, test plan ideas or something like that. But when you give us the recommendation, especially since so many of us are not experts in this arena, to the extent you can give the specifics of the recommendation, here's what you need to ask for. And that doesn't mean you're going to be able to get every single detail in there, but clear enough and specific enough for the people that aren't experts to be able to say, okay, I understand what that recommendation is about, so we can debate it and, and tweak it or whatever we're going to do to it. We've still got a couple of questions here, so Representative Hammer, you're recognized for a question.
Thank you. I want to give you an analogy and tell me if I'm looking at it right, because you've given us a ton of information here today along with everything else. Right now, everything's kind of operating. I grew up on a farm. You'd have like 6 silos in a row, but if you didn't have an auger system at the top connecting them, none of them communicated, none of them were able to transfer to the needs based on where the silos were full or low. What we have now is a silo effect among all these entities, and what we need is that auger system at the top that says you need services in silo number 3, but you don't need them in silo number 5. And what you're going to help bring to the table is that auger system that shows us, or we need somebody that can put that auger system in place so that we can transfer needs between the silos. Is that a fair analogy?
I would have thought it would come from Representative Collins. It was a great analogy. He gives great ones. You're right on.
You're the best, Representative Hammer.
Whatever. Thank you. The second and final question is this. Have you done any research in any of this as far as, say, for example, in the nursing home industry, bed placement and bed utilization, say 30 days out prior to the death of the patient, to see if the utilization of beds and the way in which those beds are being billed for, whether, say, for example, in a skilled bed, did you do anything in any of your research that looked at that area specifically?
I mean, we haven't looked at bed utilization there. We looked at overall utilization of capacity, how many were able to be transitioned into the community, how many were able to be converted from going into nursing home, so on more of a global. And we looked at these other states, and we're going to provide you with some of those examples.
All right, thank you. Thank you, Mr. Chair.
I believe Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. I believe you used the term 17% in Texas expected use. 17% of what?
That I can't tell you. It would be 17% of the total financial construction of what they anticipated they were going to be able to transfer from some of their waivers into CFCO. They're going to maintain their waivers. There's one small service waiver that I believe is 100% state funded. They expect to extinguish that. That was the design of the CFCO, was to extinguish the need for 100% funding in this one particular waiver amongst their series of waivers they have in that state. They've been litigated heavily, and they've got a history that they need to comply with. They're still under litigation in the system, in developmental disabilities. So their CFCO is designed for Texas's ability to get a significant amount of match for a service that had been 100% state funded right now. That's what the transition is.
Okay, and that was something that was anticipated before they implemented it.
Pardon?
That was something they anticipated before they implemented it.
Absolutely, that's the
Yeah.
basis of why they did CFCO. Their legislature required 2 sessions for them, for DHHS, the Health and Human Services Commission, to convince the legislature that going to an entitlement in this construction was beneficial to the state of Texas. You don't have 100% paid waiver service.
So it looks like this was only 3 months ago, so there's no data yet
Right.
on the actuality.
That's correct, sir.
Thank you.
Yeah.
Thank you, Mr. Chair.
Senator Chesterfield, you're recognized for a question.
Yes, Mr. Chair, and it has absolutely nothing to do with this, but I would like to ask the question anyway. We talked about in the past people's use of the emergency room as opposed to primary care physicians. I'm trying to find out if we have drilled down as to why they go to the emergency room. Having just experienced a finger being sliced and bleeding, I decided that the hospital was a better place for me than my primary care physician. So I'm just wondering if we have done anything at all that deals with why, because all we hear is people continuing to go to the emergency room. If I'm shot, I'm going to the emergency room. If I'm sliced and diced, I'm going to the emergency room. And thank God the finger is healing finally. But I'm just wondering if we looked at that, and if we have not, then I think it would be helpful, because there is a reason sometimes when the emergency room is a better choice than the primary care physician. And as I said, Mr. Chair, it has nothing to do with this, but it is of interest to know as we look at
Thank you for the question, Senator. I'm going to let Stephen answer that. He's looked at emergency room usage here in Arkansas.
What we've heard from our both our meetings in the community and with providers and from some of our other research has been largely that these populations, particularly those on the private option, have historically generally not had access to health insurance, and so have a level of a lack of knowledge of really how to navigate the system. And so some of our recommendations are going to involve greater outreach and education to these populations along those lines.
So they will then be better able to make a choice as to whether or not they use the emergency room as opposed to the primary care.
Yes, they'll be more aware of their options and kind of the best way to navigate the healthcare sector.
And would you remind me of how much we would save with this community first choice option? Is this based on data from a number of other places, as I was unavoidably decided?
Senator, we weren't asked to do any type of financial modeling, just to set the stage for you to listen to the department. It'll be the first time we've seen Director Seelig has sent us the slides and the data that they used a few months back, and so we've looked at some of it, so we have some understanding. We want to continue to listen, and we'll have something in our final report. On the ER issue I want to raise, we also have looked at all the claims, PO and Medicaid. So when we come in and say, there's a non-emergent use, which we're seeing a high level, that's based on codes that we've looked at, that through CMS's designation and through research, scientific basis, identify codes that are being used for not really emergency basis. And what happens is the carriers have an appeal process. And the ones we looked at for the claims were after that appeals process as well. So it's pretty clear that there is still that issue. And Richard and I, when we were in Delta, we had heard personal stories about folks not being able to go to the physician because the wait was too long. And so they just used the emergency room, which I question whether that is an accurate, because I think when we talk to the companies, that the agents, we had a conversation, Mr. Chairman Collins had asked me to talk to the agents. We had a long discussion with them. And you have your carriers. You have so many out there that are able to provide some information, but it seems like it's not being coordinated. And if it's coordinated and the communication's direct, I think that problem somewhat will be solved because you do have primary care physicians out here in the state that are taking those populations.
Well, I agree with you 100% on that, but there are also instances, for instance, in my hometown where you have to sit and wait for 3 or 4 hours.
Yes.
And you're very sick, and you feel you need to go somewhere to get some help.
And I don't know how you would be able to, from a policy level, really truly address it other than outreach and being able to help identify other available alternatives.
All right, thank you. Thank you, Mr. Chair.
Okay, so right now, we're right over 11:30. I've still got a couple questions in the queue, so here's what I'd like to propose. If you're adamantly opposed to this and you have a question in the queue, I want you to wink at me or something. But what I'd like to do is break for lunch now and come back at 1 o'clock. The Stevens Group is going to be back on the floor this afternoon to talk to us about some other issues, and I will put the people that are currently in the queue at the front of the queue for that time period to ask their questions. Because I want to establish that we're going to break at 11:30 during these meetings for lunch. Is that okay? I think the Stevens Group is K, if I'm not mistaken. So, excuse me? All right, Senator Organ, you recognized for a question.
Are they going to be back at 1 to be able to ask questions at 1, or are you talking about like 4 or 5 o'clock?
I think it's 4 or 5 when they're back on the agenda.
Well, may I ask just a quick question?
Yes, you are
related to
recognized.
what Senator Chesterfield?
Yes, you are recognized to ask
I
a
just
question.
wanted to point out what Representative Murdoch's meeting that was held, and the report that they did, which is in the book that addresses exactly what Senator Chesterfield said. But I do think there are policy issues at play with the usage of emergency rooms, and why primary care physicians sometimes do treat people and sometimes don't treat people. There's a lot of instances where things could be taken care of at the clinic level, but because of the way the payment is structured, they're not. And they're sending those things to the emergency room, which I would deem as non-emergent. So yes, those are policy changes that could be made, but when you're getting paid, $50 to do a skin tag removal or a sliced finger, and you can sew that sliced finger up or remove a fish hook in a primary care setting in a clinic, that's a non-emergent situation that's going to show up at the ER. But if you're only going to get paid $20 to do it, they're just not going to spend the time to do it. I do think that needs to be addressed, and when you're looking at that, and if you look at the comments that were made, it's along those same lines, I think. But could you address those things from a policy point of view?
You sure can, and there are some areas, but I would start with, again, outreach and education to the community to let them know what is the most appropriate use for ER and what other services are available. That's the other part is really missing, because they might not know what else is out there available. But yes, we can address a few of those. I think in our overall recommendation, we're going to be looking at a couple paths for you, and we'll talk about that this afternoon. And I think within both of those structures, those rules, regulations, policies will be looked at, because we're going to recommend that you start putting risk, value, and incentives on that type of activity, so that if people properly are able to help coordinate care and keep folks unnecessarily out of those settings, they ought to be rewarded for that, if there's a reward that could be given within an incentive system.
Thank you. That was my question.
Thank you very much, Senator. Okay, with that, we're going to break for lunch. We'll be back at 1 o'clock. We'll start with agenda item E, number 1, Mental Health Council of Arkansas and 1 p.m.